NACDL is the association of the nation's criminal defense bar.
And today I really want to focus this presentation on understanding how everything we know about addiction as a disease and approaches to treatment are really in direct conflict with the criminalization of addiction and draconian measures like the homicide-induced sentencing and harsh penalties that still exist through large parts of the United States. So by the end of the presentation, I hope that you can define addiction as a chronic medical disease, a disease of the brain, and how this relates to the criminal justice system, understand how opioids work, understand the pharmacokinetics and pharmacodynamics of opioid overdose, define how social dynamics of drug use are related to overdose, and identify overdose prevention and response strategies. So we're going to start by going through the definition of addiction and the neurobiology, then move on to specifically looking at opioid use disorder, opioid prevention and response strategies, then review the intersection of addiction and the criminal justice system and the role the legal community can play. And I have a list of resources at the end, as well as a whole bunch of additional slides that you'll all be very grateful for. Leo took many out of this presentation. Which can be available through Bonnie or through myself at any time. So I just want to first define what a substance use disorder is. It's a diagnostic term in the DSM, which is like the Bible of psychiatry, and it's defined as the recurrent use of alcohol or other drugs causing significant impairment, such as health problems, disability, and a failure to meet major responsibilities. This definition replaces the DSM-4 definitions of substance abuse, which is a stigmatizing term that we try to avoid in our language and replace with person-first language. And it also replaces the word dependence, which is a misnomer, as you can be dependent on a substance and not be addicted, and you can also be addicted to a substance and not have dependence. Addiction is the most severe form of a substance use disorder, and we grade substance use disorders as mild, moderate, or severe. So one of the major tenets and definition and part of the definition of addiction is the concept of use despite harm. And I think this is particularly important for lawyers and legislatures who are working in the criminal justice system, because punishing those with substance use disorders for their use is ineffectual. This is a quote from Mai Salovitz, who is a reporter, author, and also someone who struggles with substance use themselves. And I think it encapsulates this concept really nicely. So we have this idea that if we are just cruel enough and mean enough and tough enough to people with addiction, that they will wake up and stop. And that is not the case. Addiction is actually defined by the DSM and by NIDA as compulsive behavior that continues despite negative consequences. That's the definition of addiction. So therefore, if punishment, which is just another word for negative consequences, worked to fight addiction, addiction wouldn't actually exist. Addiction develops in sort of a very complex environment, and many of the predisposing factors for addiction are completely out of control of your clients and my patients. So some of these are genetic factors or heritable factors, and also how our genes interact with the environment through epigenetics that also can predispose folks to developing substance use disorders. And then the environment itself in which we grow up and live. And so that context, a person can then be exposed to either drug and alcohol use, which interacts with our brain. And ultimately, some folks can go on to develop a substance use disorder or addiction. Some well-known concepts or root causes of addiction from the environment include trauma. This includes physical, emotional, sexual, and spiritual abuse. There are good, large epidemiologic studies that show people who experience adverse childhood events, which is a synonym for trauma, are 2 to 4-fold times increased risk of developing a substance use disorder in adolescence and adulthood. And if someone's experienced more than 5 adverse childhood events, they are 7 to 10-fold more likely to develop issues with substances. So that sort of provides some context about genes' environment, which sort of predispose folks to developing substance use disorder. And then the next part, we're going to take a little bit of a deeper dive into the neurobiology of addiction. So when we all have a reward system in our brain, in the mesolimbic part of our brain and in the prefrontal cortex, that exists to sort of sustain our life so that we continue to do things like eat, have sexual intercourse, etc., that we then perceive as pleasurable through the transmission of dopamine, which is the sort of feel-good neurotransmitter in our brain. And so this reward system is active and being like utilized in all of us. And this is the system that is also highly activated when someone injects a drug such as an opioid or methamphetamine or cocaine. And there are traditionally sort of 4 phases of addiction, 4 phases of drug use that then can lead to addiction. The first is the binge intoxication phase, where people use a substance, have a euphoric sort of experience, and then continue to seek that substance and that positive reinforcement to experience that again and again. While this is happening, this dampens sort of our experience of reward overall. So not only do people experience less reward from the substance that they're using, but they also no longer experience the same kind of reward or pleasurable effect that we do when we have a great meal or have sexual intercourse or spend time with friends and family. And so those things become much less and less and less important. At the same time that someone's seeking sort of this euphoria, when the drug is removed, they also experience really intense dysphoria and craving, which then leads to further substance use. While all of this is happening, the substance itself affects the prefrontal cortex, which is the part of our brain that is responsible for executive functioning, which is the part of your brain that allows you to make responsible decisions and not just act on impulse. And so that's directly affected by the substance themselves. And so people who then have compulsions to use are unable to sort of say, no, I'm not going to give in to that impulse, and this results in relapse. Now we're going to focus specifically on opioids and opioid use disorder, which is a specific substance use disorder. So opioids work by attaching to specific receptors in our brain, as well as throughout our neurosystem. And an opioid is really any substance that it binds to these receptors with a high affinity. So this could be things like heroin, which is an opiate or a natural occurring opiate, or a synthetic opioid like fentanyl or carfentanil. And the pharmacokinetics of opiates is determined by 2 things. It's determined by the drug itself. So is it a short-acting or a long-acting opiate? Is it strong? Is it weak? And it's also determined by how we use the drug. So as you can see in the right-hand corner, if you ingest an opiate, it has sort of this slow up and slow down. You can feel the effects coming on. It's not that intense. Whereas if you use it intranasally or intravenously, you have this really intense peak and really intense trough, which gives both the euphoric effect, but also causes some of the negative consequences. The negative consequences are also determined by the pharmacodynamics, which is a fancy word for how strong does a drug bind to these receptors that then cause an effect. And so fentanyl, for example, is very sticky and very powerful. So when it gets into your system, it binds with a really high affinity to what are called the mu opioid receptors that are distributed throughout our body, throughout our brain and nervous system. And so this is what gives the intense euphoric effect in our reward system, but also there are mu receptors in our midbrain, and that's the part of our body that is responsible for controlling things like our respiratory rate. And so if you have a lot of opioid on board and it's binding to those receptors in your midbrain, it can also cause respiratory arrest as well as a host of other sort of physiologic changes. And these are sort of the elements that are involved in drug overdose. So we reviewed how a drug and its pharmacokinetics and pharmacodynamics are important in understanding drug overdose, but there's also very important psychosocial factors that we know increase risk of fatal overdose. And I really like the paradigm of drug set and setting, which was originally used to describe a drug use experience, but also can be applied to overdose risk. So the drug, as we've already discussed, is an important component, but also if that drug is being used in isolation or with other drugs. So things like alcohol and benzodiazepines used in addition to opioids actually potentiate each other, meaning they kind of stack one on top of another, both increasing sometimes the euphoric effects, but also increasing sort of those really serious side effects like respiratory depression or decreased mental state. I think this is really important for a few folks here because polysubstance use is extremely common, actually more common than using just one substance alone. And so saying that someone died simply because there was fentanyl in their system is probably oftentimes a large oversimplification of what actually sort of led to their fatal overdose. Someone's mindset also affects how they're going to use drugs. For example, if someone had a fight with a partner or girlfriend or boyfriend, they may be feeling particularly having a really strong drive to use and might use less carefully than they would otherwise. And then the setting is extremely important. So if someone's tolerance is changed because they've just been forced to detox either in incarceration or voluntarily detox, they are at higher risk of overdose. Post-incarceration, it's 130 times greater risk. And also using alone is a major risk factor for overdose, especially in the context of an incredibly toxic illicit opioid market where fentanyl and other synthetics are really the norm and not the exception. And this sort of just further underscores the importance of polypharmacy in overdose. As you can see, this is from 2014, and I can tell you that more recent data would also sort of support this trend, that most opioid overdoses are not secondary to just using opioids alone, but they're secondary to using opioids plus another substance, the most common substances being benzodiazepines or alcohol. And so this brings us to, so what do we do? How do we respond to this epidemic? And how do we use the knowledge that we have about addiction science and risk factors of overdose to respond to the opioid epidemic? And one of the main tenets, I believe, and is supported by the evidence, is treating and using harm reduction tools as a way to respond to the crisis. Harm reduction aims to lessen the negative social and physical consequences associated with drug or alcohol use and really is the opposite of harsher sentences or the war on drugs. It approaches people who use drugs as people and provides dignity and safety and will meet people where they're at instead of telling them where they should be at, which is a far more productive strategy. This is a picture of Insight, which is a safe injections facility in Vancouver, where I spent some time and continue to work. And so these are overdose prevention and response strategies that I use every single day in my clinical work discussing strategies with my patients. And these are all strategies that are really based in the philosophy of harm reduction. So whenever I talk to one of my patients, I really emphasize not using alone and using their social network to stay safe and to have each other's back. And to try to stagger their use so that if someone uses and they go down, the other person is there to respond. I'm encouraging folks to use drug checking services, which are becoming increasingly available in Canada and the United States, so that they have some more agency and knowledge about what substances they're putting in their body. We like to say start low and go slow, which is also the same philosophy I apply to all my geriatric patients, but it's a little less relevant with fentanyl, but still a message that we do communicate. I always try to make sure that my patients understand what an opioid overdose looks like and then have the knowledge and capacity to respond to the overdose. Most people who are reversing overdoses are other people who use drugs. They are the first line of defense, and they are doing a lot of the hard work out there on the streets. And so that means they have to have naloxone on their person at all times, or that naloxone is widely distributed in the community. Of course, we want folks to seek professional help. We know that medications for opioid use disorder reduce fatal overdoses by greater than 50%. But in order for folks to seek help, we have to work on decreasing stigma, making it accessible, and removing isolation as a variable that increases overdose risk. I really like this study done by some of my colleagues in Vancouver, which is a setting where there's like low barrier access treatment and actually more treatment options available than here in the United States. But as you can see in the graph in the top hand corner, most overdoses prevented they estimated in 2016 to 17, there was over 3,000 overdoses prevented, over half of which were prevented not by physicians treating patients with addiction, but by folks having naloxone in the community or take-home naloxone program. And it's the brown part in that graph. So that is one of the most productive public health strategies in preventing overdose deaths, in addition to having overdose prevention services like Insight and safe consumption places, and of course, access to treatment. So this is the natural history of opioid use disorder, and it's also the sort of cycle that we hope to interrupt with treatment. So once someone becomes dependent and develops a tolerance to a substance, they are really in the cycle of using just to feel normal and avoiding the really negative, seriously traumatizing experience of withdrawal. And giving a medication like methadone or buprenorphine is just a tool for someone to then feel normal and sort of be able to re-engage in normal activities of daily living. And there's sort of two historical approaches to treatment. One is detoxification, which I hope will soon be sort of removed from the medical lexicon because it's not a terribly effective, in fact, quite ineffective strategy to address addiction, where we quickly wean people off of opiates or other substances, sometimes with pharmacologic support, sometimes not. And the relapse rate is greater than 80% and is actually linked to increased risk of fatal overdose if there's no sort of support for future treatment post-detoxification. Whereas treatment with either pharmacotherapy plus minus counseling and hopefully counseling and supports decreases relapse rates by 40 to 75% and is associated with a 50% reduction in mortality. Some other additional patient benefits in addition to decreasing mortality, which is maybe arguably the most important benefit of any medication that I can prescribe as a physician, are decreasing other harms associated with drug use, like infections, skin and soft tissue infections, et cetera, and being retained in care. And there are also really large public health benefits. Treating people with opioid use disorder with medications decreases hepatitis and HIV seroconversion, decreases criminal activity in the context of a government that still continues to criminalize addiction, and increases employment engagement in sort of our economy and social services. So despite these obvious known benefits, there are massive treatment gaps, and overdose continues to rise in Canada and the United States. And as you can see, about 90% of folks with substance use disorder do not have access or not engaged in treatment at this time. And also, perhaps most disturbingly, about 90% of folks with severe mental health issues and substance use disorder are also not in treatment. So we have a lot of work to do. I'm going to quickly talk about incarceration in the U.S. You folks probably could teach me a lot more about this than I but I think it's important to connect this with addiction because they're sort of inextricably linked. The U.S. leads the world in incarceration, and incarceration is not experienced equally amongst sort of U.S. citizens. Race is a major factor in this disparity. And since the war on drugs, there are more people incarcerated today, secondary to drug-related offenses, than the entire incarceration population in the 1980s. 65% of the United States prison population has an active substance use disorder. An additional 20% were under the influence of drugs or alcohol at the time of the crime. Providing comprehensive substance use treatment to criminal offenders while incarcerated is effective, and not treating is associated with fatal overdose post-release, and is also illegal. In 2005, the WHO said that medications for opioid use disorder are essential medications. Other essential medications would be things like treatments for tuberculosis or HIV, and they should be available to all prisoners with opioid use disorder, which is still sort of not the case in the United States. And so what can you do as lawyers to help address this? Folks who are involved in the criminal justice system and have an addiction are often still forced into detox, either through civil commitment programs like Section 35 in Massachusetts, through DCF or child services, or of course the criminal justice system. And this is infringement on individuals' constitutional rights. And Sally Friedman won a case, and she said this case should serve as a wake-up call for states and localities across the country. The common practice of denying medication-assisted treatment, which we now refer to as medication for opioid use disorder, in correctional settings, not only increases illicit drug use, overdose, and death, but it's illegal. And so that sort of brings me to the conclusion of this talk, and I just want to quickly review some pearls. So I want to emphasize that addiction is a chronic, relapsing, and remitting medical disease, a disease of the brain. It's not a moral failing. Punishing people who use drugs is a futile strategy to address addiction. The criminalization of addiction perpetuates stigma. It interrupts treatment. And incarceration is linked with increases in fatal overdose. Overdose is driven by isolation and barriers to help seeking. Take-home naloxone, harm reduction, and medications are standard to treat and prevent overdose. lawyers in the entire legal system may play an integral role in enhancing addiction treatment. So I hope that I was successful in achieving my objectives. I hope that there's some questions after Lisa sort of brings it home and makes this more applicable to you in your work. And I have a list of resources here of sort of websites with good evidence-based information or government bodies with evidence-based information and statistics relating to substance use and addiction. And I also just wanted to highlight some books and movies and podcasts. There's tons out there, but these are all books or podcasts that I've read myself and I think provide interesting perspectives on substance use disorders and also the opioid epidemic and give some context of where we are today. And there's I have materials and resources. If you're interested, you can get the slides from Bonnie or myself. Thank you so much.
As I said, I'm a lawyer. I practice a public defender. I also am a clinician. So in the middle of my law career, I went and did a master's in social work. I worked as an outpatient addiction therapist with many of my clients being on probation and parole with drug-free orders and seeing how the court system was interfering with the clinical process. And then I worked at the maximum security prison as a mental health clinician in Massachusetts. Before I went back to law, I've worked in the drug courts, our district superior courts, and have done appellate work. So my passion has really intersected around how we are treating people with addiction in the criminal justice system and how we can use the science. So once I worked clinically and then I went back to law, it really brought home for me how what we're doing in the court system does not make any sense. And we have to get creative as lawyers about how to try to change the status quo. So the first thing is language. Language is so important. We are advocates. What we say matters. How we frame an issue matters. So when I say if you take nothing else away from this but the slide, you should hopefully take more than that, but please at least take this language. Get rid of the term substance abuse, because what do we think about when we think about the term abuse? We think about physical abuse, sexual abuse, child abuse, really horrible, horrible things. It's not an accurate term. Nobody is beating the crap out of a drug, okay? So it's not accurate as just a grammatical phrase, and it's highly, highly stigmatizing, and there's been research done around this. I don't have enough time to explain, but basically the research is very clear. When we refer to someone as a substance abuser, the listener is more likely to think, even a PhD level clinician is more likely to think that that person is morally culpable for their drug use and should be punished. So as lawyers advocating in a courtroom and negotiating with prosecutors and dealing with probation, we have to stop using this word. NIDA, National Institute of Drug Abuse, unfortunately it's a government name, so it takes time to change these things, but there's a real movement to stop that term. So substance use disorder, or someone's engaged in substance use or misuse. So when we're talking about somebody, let's say, who's using a prescription opioid, let's say a Percocet or something of the like, they're not abusing it, they're misusing that if they're not using it as prescribed. Other terms, for example, would be, so clean versus dirty. We don't want to refer to our clients as dirty or somehow clean. If it's a drug screen, it's not a failure if the drug screen comes up positive. Bringing in clinical terms, positive toxicology screen, negative screen. So another term, drug of choice. That is not, when somebody is suffering from addiction, the choice is no longer there. So it is a drug of addiction. So we want to try to get rid of that term as well. And then getting to the person first language, the person with a substance use disorder, a person who uses, a person who is addicted. So this is really, really, really important in our advocacy. Okay, so we already have heard all about it, but to just hone it in really simple terms. What is addiction, i.e. severe substance use disorder? It's intense cravings and compulsive use that continues despite negative consequences. There's a physical and mental tolerance that drive the person to use a drug of addiction as if life depends on it. And so when we're talking about drug-induced homicide cases, especially when we're talking about the person who's being charged with this crime as being someone who's using and has provided drugs to, let's say, a friend, acquaintance, or a loved one, it's not about trying to do something reckless and crazy. It is about trying to deal with the horrific process of withdrawal. So I'm going to go back to that slide in a minute. Sorry, moving ahead, I want to say, so when a person is struggling with drug addiction, they typically ingest multiple times a day in a desperate attempt to stave off withdrawal. So that use of the drug is required to feel normal. So again, when we're talking about drug-induced homicide statutes and the courts have deemed that it's reckless to provide any amount of heroin to somebody, not for somebody who's addicted, not when people are addicted, there's nothing reckless about it. It is about trying to feel normal. So our argument that Jeremiah and Leo and I presented in the Carrillo amicus brief that I mentioned earlier is that if the defendant suffers from addiction and provides drugs to a fellow user, the defendant's purchase of opioids for a addicted person is not reckless in view of the science of addiction. So that was the thrust of our argument that the court actually solidified into law. We didn't win on the drug distribution aspect of it, but on the involuntary manslaughter part of it. So what do we want to be arguing as lawyers? Severe substance use disorder, since it's a chronic illness in which changes in brain circuitry and physical tolerance to the drug drive a person to daily compulsive use as if life depends on it, then if the defendant and the decedent both suffered from addiction, the defendant's purchase of that substance is an act to manage the illness. It's not one of recklessness. Okay, so, sorry, here we go. Sorry, I'm all over the place because I switched my things around. So as lawyers, I think it is really, really important to ground ourselves in the Diagnostic and Statistical Manual, the DSM-5. Every defense attorney office should purchase the DSM-5, have it as one of your essential law books, because so often what we are dealing with who are people who are addicted. And I will just say as a side point, on my soapbox, when we see these statistics about 65% of the people who are in prison have an addiction, much of that is because of drug prohibition. It is because of the fact that we have outlawed drugs and made people run around and spend their whole lives trying to figure out how to get a drug. Prices are skyrocketed. That is what often is leading to the crime. When I am in court, more often than not, alcohol is the one drug that seems to be causing people to act recklessly in terms of getting into fights, committing assault and batteries. My clients who are using opioids aren't really bothering anyone except for the fact that they can't get opioids and they can't afford it. So that's where the theft comes in. So I know that's a tangent, but I just feel like we're sort of running a line here where we say so many people in prison have an addiction, and then we say, but we need to treat them with compassion. We have to recognize that we've created the dynamic that has led to people being incarcerated. So everyone needs a DSM-5. I highlight especially page 483 of this book because this is where we get a good description of what addiction is, and it's what we should be putting in our memos and briefs to the court and when we're arguing before judges about why there needs to be compassion, or we need to be letting people out on bail with treatment or probation conditions with treatment, or if somebody uses while they're on probation. This is why, because a court can't just order a person to be in remission or cured of an addiction. So again, just as practitioners, understanding that in the DSM-5, as Miriam had mentioned, the substances are categorized, and each one is more or less the definition is similar to mild. It's similar from mild, moderate to severe, but they're separated by the class. So you'll see again in the DSM-5, in terms of the mild, moderate, and severe, if you have 2 to 3 symptoms, you're in the mild category, 4 to 5, you're in the moderate, 6 or more, which is often what we're seeing in the criminal justice system, is that severe category, which we call in layperson's terms, addiction. So the Surgeon General's report is another really good report for us to use as lawyers. It's really intense. It's really long. It came out in 2016. This is the major report from the medical community. The whole point of the Surgeon General is to put together all of the leading science and tell us what we as a society should be doing. So when the Surgeon General is telling us that this is a chronic relapsing disease and that people's essentially willfulness to use is not there when you're addicted, these are arguments to be used in court. So just moving forward. Okay. Here's another thing, medical consensus. I just like to really pound in that we have all of the major medical bodies, even in the world, agreeing about what addiction is, but somehow our courts and the legislature still remains behind in terms of our laws. Okay, so in terms of our client base, the risk factors, trauma. It is at the top of the list of risk factors for the people who are in prison. You know, when I work as a clinician in prison, every single one of the men I worked with was so highly traumatized as a child. And the risk factors for either genetics or the environmental, the trauma is intense, and the use of a substance had a productive quality to it because it was help easing the pain of all of that trauma. And so this idea that hurt people, well, also as a society, we are hurting people. We're hurting traumatized people who really need compassion and really need help. Shame is at the heart of addiction. And when we shame people, it is very hard to show our face and get help. And so, yes, addiction can hurt families, hurt loved ones. That is absolutely to be taken seriously. And I am not one to say that the family members or loved ones are the ones who have to be the ones providing the help, but this is why we end up having professional help, because sometimes we need other people to help hold the people in our lives who are most ill and struggling. But our incarceration system is about shame. Hold on, here we are. Right, so prison, this is what, this is the basics of what prison looks like. That's the prison where I work, Sousa Baranowski Correctional Center. That is the rec cage at Sousa Baranowski Correctional Center when men who are in the so-called treatment program in solitary confinement go. This is the absolute opposite of what helps to get people better. So again, when we are arguing in the court and it's about a disposition between being, sentenced to a long period of time versus trying to do something more productive and getting probation conditions that will help people, this pie chart by Dr. Ruth Pody, who runs in Massachusetts, one of the jail medical programs, it will say she runs a great program in her jail, but jail is still not where people should be to get their treatment, because inherently at baseline, it cannot have the qualities of what we need. So what it takes to get better, there's a whole list, but stable and sober housing, positive relationships, hope, having a sense of purpose, physical movement, exercise, growing into an adult brain, effective medicine, working, getting treatment for trauma, feeling accountable for oneself, mental health treatment, sometimes parenting. So all these things, sometimes I think people can be like, well, it's a little mushy. How is this science, et cetera? But this is what helps people get better from most mental health issues. We need a good grounding of at least some portion of these. So not like every person needs the entire pie chart, but people need a certain portion of these to click in and be able to get healthy. So essentially, we need to help people rebuild the brain's dopamine system. And so medication is one thing, but there are also addictions that medication doesn't treat. And so there are all these other aspects. This is just a written out list of essentially what's on that pie chart that help people get better. So that's not what prison and jail are doing for people. These are other, further components of what we want to be arguing for and what our clients need. Again, it's not in jail, in prison. So compassion is at the heart. It's really hard work. I think we all have probably had clients who've driven us out of our minds. And I know I drive people in my life out of my mind for different reasons. So, we have to hold a space for people, and I know it's challenging, and we all need to have self-care around that. But at the heart of all of this is trying to hold some compassionate space within our system right now that is working towards it, but is so far off from it. And so just as a final note, though, probably the only reason I'm even kind of here is because of a case that I brought in Massachusetts, where I argued that it's unconstitutional to order a person with a substance use disorder to be drug-free and then incarcerate that person for relapse. So the case did not win in a manner of speaking. It was dodged in many ways. Our Supreme Judicial Court dodged the question and claimed that we didn't present enough evidence when, again, we presented the Surgeon General, the DSM, and experts, et cetera. But in a way, the argument was pushed off for another day. But I continue to push this argument because I think it's really where the law needs to go. The court cannot order someone to be cured or put into remission of their addiction. So right now in Massachusetts, we actually have legislation pending that would accomplish what this did not do, and that's getting some movement. So stay tuned on that. So essentially, this is just a final slide that encapsulates what I've said, but I'll just say the final part of it is, as a clinician, when I was working with people on probation and parole, these court orders, ordering people to be drug-free, incarcerating people for relapse, it really, really, really interfered with authentic treatment because my clients who were afraid that they were going to go to jail because we'd have to turn over the drug testing, then they stopped coming in when they think they're going to test positive. So you have people then dodging treatment, and it turns into this really distorted, dysfunctional system in which clinicians want to put their patients first, but the law is making it really hard to do that, and we're playing a cat and mouse game all the time, and we have to stop doing it. So are there any questions? What is my opinion of drug treatment courts? So my basic answer is it's a mixed bag, but I am highly, highly cautious based on my experience in them. So I want to be clear that I can't speak for all drug courts across the country. What I can say is that my experience in the drug court is that it was what I've been talking about at a maximum degree. And so judges run their own fiefdoms in each of these courts. It depends on who that judge is, what their understanding of addiction is. I was in a drug court where the policy was we're incarcerating people if they have any drug use. That is not what the National Association of Drug Court Professionals says in their evidence-based manual. They make clear that you should never incarcerate anybody for more than a few days. But that being said, when you read the fine print in that manual, it even says that once you go beyond essentially a week, you're getting negative outcomes. It's like 1 to 2 weeks. You're starting to actually get negative outcomes. But there's nothing in it that actually says you're getting a positive outcome for even holding someone for a few days. And we all know that you could somebody can lose their job, lose housing, all that. And so I had a very bad experience around the constant incarceration for drug use. So that is what I would say my main concern is. That being said, I have heard of drug courts where the real mandate is we are here to hold you and help provide you treatment and help you through the process. And the benefit to you is that you get to have a case dismissed, or you get some good legal outcome. I think my main real cautionary point on drug courts is that we are having judges, lawyers, probation officers doing medical work. So in Massachusetts, at least, the people in the drug court have to go to a 2-day training. When I think about us as lawyers doing a 2-day training, a medical doctor doing a 2-day training on law and suddenly being told you're going to preside over a trial or evidentiary proceeding, it would be absurd. Both of these professions, medicine and law, take years of work. And even as lawyers, we're all still learning, 20, 30, 40 years into practice. So my real concern about them is that it is allowing people to practice medicine who shouldn't be.
Drug courts, again, sort of really are in conflict with what the best evidence is to approach substance use disorders, which is really based in motivational interviewing. And the sort of root of motivational interviewing is autonomy. And when you remove someone's autonomy, it's very hard for them to take responsibility of their sort of whatever chronic condition it is, be it diabetes, hypertension, or addiction. And in a drug court, a person does not have autonomy.
And I imagine my question would be valuable, helpful to lawyers as well as, what can you tell us about treatment for people whose substance abuse disorder is linked with a long history of extremely violent behavior.
Sorry, you're asking how do we treat that? How do we deal with that?
Yeah.
Yeah.
And do you know models out there that we could study and also lawyers could recommend people to go to?
I think in general, you're bringing up a huge problem that I think about a lot, not really just in terms of addiction, but just in terms of violence. So I work with many, many men in long-term prison sentences right now who have behaved extraordinarily violently in their past. And I think as a society, we have been very, very poor at dealing with youth who are acting out aggressively and violently in reaction to trauma, which is the case of all of my clients. They weren't just born being violent. They're traumatized, being abused, and then behaving aggressively. My short answer is I don't know of good programs, but on the big picture of what we all need to be moving towards is how do we, similar to addiction, work with people who are traumatized and behaving aggressively, because what I found with the men I work with right now, I have 14 clients who are serving life sentences. So I'm in prison dealing with men who've done tons of years in solitary confinement, a lot of violence, right? And all of them, I think it's fair to say, have developed an absolutely appropriate positive bond with me and can be regulated when treated with compassion, fairness, and an ongoing dedication. That is not what our systems do. So prison is all about you are the other, you are bad, and we as people buy into the stories we're told. If you're told you're a criminal, you're bad, you're violent. And so a really prime example, and then I'll turn it over. I have a client who did 13 years in solitary confinement, and he'll say, "You're going to treat me like a savage, I'll behave like a savage." And that refrain is so common. So my general answer to that is that this is also the big think about how we are working with people who are dealing with violence and aggression again, because it's not coming out of nowhere. So that may not be a satisfying answer, but that's my kind of big picture thinking on it.
I guess I would just add, as a clinician, I would think about sort of unmet or undiagnosed, really severe mental health issues that probably have gone unaddressed since adolescence or even early childhood, and how important it would be to have a psychiatric evaluation in those instances, and also the context of drug use. As Lisa sort of really eloquently said, perpetuates a cycle of violence. You have to be violent to survive on the streets. You have to be violent to protect yourself and to continue to support your drug use. And so getting people engaged in treatment can also help interrupt that cycle of violence.
So what I'm going to do, I know...
Hi, I'm Christopher Maraff. I'm a journalist from Philadelphia. And I would just say in terms of...
It's going to be the last question.
Yeah, and it's more of a commentary on what you were just discussing here. I've spent 2 years immersed in the opioid population in Kensington, and it's probably the least violent association of people I've ever met, more likely to be victims of violence. So I would think that in terms of violence, there's probably some underlying issue there beyond drug use. Drug use may happen as a result of the trauma as well, but drug use alone, particularly among the opioid population, does not generally cause violence. The crimes that are committed are low-level retail thefts, stuff like that. Most people shy away from straight-up hurting people, you know? But then when we put in place policy decisions like increased enforcement, it creates tension, chaos. Then we see increases in violence. You know, so we have to think about how our policy decisions are creating the environment that we want to address. You know?
Yeah, I 100% agree. And I just want to make sure I clarify. My 14 men are on life sentences. None of them were related to addiction. They were related to the drug war and being in communities that we have decimated with the drug war and locked up all their fathers and many of their mothers and parents dying of AIDS and their population being criminalized. So, I want to make sure I didn't distort. I kind of went into a different topic. Yeah, so I completely agree with you on that. Thank you.